It's 2 a.m. and your pager goes off. Patient room 404 has a temperature of 101.8. Within seconds, a wave of decisions hits you. Is this a true infection? Do I start antibiotics? Or can this safely wait until morning? In today's episode of 2am Medicine, we are breaking down the 5 critical mistakes clinicians make when evaluating a night shift fever. Mistakes that lead to overtreatment, misdiagnosis, and patient harm. If you are surviving overnight calls, hit subscribe. We are focusing on the practical real-world decisions you have to make when there is no attending or someone around to ask. Mistake number 1. Thinking every temperature elevation requires immediate intervention. One of the most common overnight mistakes is assuming that every temperature elevation requires immediate action. It doesn't. When I get paged about a fever, my first question is not, do I need Tylenol? Do I need blood cultures? Or do I need antibiotics? My first question is, how worried should I be about this patient? Before ordering anything, I spend a few minutes gathering some basic information. Is this a new fever, or has the patient been febrile already? How high is the temperature? What do the rest of vital signs look like? Is the patient hemodynamically stable? Have they developed any new symptoms? And is there already an explanation of the fever? For example, a patient with pneumonia who started antibiotics earlier today and spiked a temperature of 101.8 overnight is very different from a patient with a new fever of 103 with rigors and no obvious source. The first patient may simply need observation and reassessment. The second patient may need an urgent bedside evaluation. I also take a quick look at the chart. Were any new medications started? Were any blood products given recently? Does the patient have a central line, Foley catheter, or surgical drains? Sometimes the answer becomes obvious before you ever place an order. One important caveat here, don't become falsely reassured by a temperature that does not seem very high in elderly and immunocompromised patients. They may have serious infections with only minimal fevers and always require serious evaluation. At 2 a.m., not every fever requires acetaminophen, blood cultures, antibiotics, or a workup. The first decision is not what to order. The first decision is how concerned you should be, because the intensity of your evaluation should match the clinical scenario. Let's move to mistake number 2, treating the thermometer instead of the patient. Once you've decided the patient does not need an urgent evaluation or immediate escalation of care, the next question is, do I need to treat the fever itself? One of the most common overnight mistakes is becoming overly focused on the temperature number. A nurse pages, "Doctor, the temperature is still 101.8 after Tylenol." My response is often, how does the patient feel? Because fever is a symptom, not a disease. The goal is not necessarily to normalize the temperature. The goal is to treat the patient. Some patients with a temperature of 102 are resting comfortably, sleeping, and have no significant symptoms. Others feel miserable with a temperature of 101 or 100.8 and may benefit from treatment. This is why I don't automatically order additional medications, cooling blankets, ice packs, or fans simply because the temperatures remain elevated. Instead, I ask, is the patient uncomfortable? Are they having rigors? Are they tachycardic because of the fever? Do they have a neurologic condition where fever control is particularly important? Is the temperature equal or more 104 Fahrenheit 40 centigrade, where antipyretics therapy is generally indicated regardless of symptoms? In those situations, antipyretics therapy may be appropriate. But a persistent fever after acetaminophen or an NSAID does not automatically mean treatment failure. And it certainly does not mean the patient needs broader antibiotics. At 2 a.m., the objective is not to win a battle against a thermometer. The objective is to identify and treat the underlying cause while keeping the patients comfortable and safe. Sometimes that means treating the fever, sometimes it means treating the infections, and sometimes it means simply observing the patient while the diagnostic pictures becomes clearer. Because navigation this nuance at 2 a.m. is tough, I've put a complete night shift fever flowchart in my Substack newsletter linked below. It gives you the exact algorithm I use to clear pages safely. Now let's move on to mistake number 3. Assuming every fever means infection. One of the common overnight mistakes is seeing a fever and immediately concluding that the patient has an infection. Sometimes they do, but not always. Fever is a sign of inflammation, infection just one cause of inflammation. This is why I never stop my diagnostic thing at patient has a fever. Instead, I ask, what is the most likely cause of this fever? Many hospitalized patients develop fevers from causes other than infection. Recent surgery, blood transfusion, new medications, DVTs or PEs, autoimmune diseases, pancreatitis, hematomas, malignancy, and sometimes the patient already has a known infection that's being appropriately treated. And one practical peer here is to review what happens during the last 24 hours. Was a new medication started? Did the patient receive blood products? Did they undergo a procedure? The answer is often hiding in the chart. Another common overnight scenario is the post-operative patients. A nurse pages, doctor, the patient had surgery yesterday and now has a temperature of 101.2. Now, many clinicians stop thinking it's probably atelectasis. But atelectasis itself has never been convincingly shown to cause fever. So don't let atelectasis become the end of your differential diagnosis. Keep thinking. Could this simply be the inflammatory response to surgery? Could there be a hematoma, a thromboembolic event, an early surgical complication, a surgical site infection? Another commonly overlooked cause of inpatient fever is a medications we started ourselves. So when the infectious workup is unrevealing and the patient looks surprisingly well despite the temperature, take another look at the medication list. The culprit may already be sitting there. At 2 a.m., don't ask, does this patient have a fever? Instead ask, what's the most likely cause of this fever? Because fever is a clue, it is not a diagnosis. Let's move to mistake number 4. Assuming persistent fevers means treatment failure. A nurse pages, doctor, the patient still has a fever despite Tylenol and antibiotics. You open the chart, the immediate temptation is to assume the treatment is not working. Maybe the antibiotics need to be broadened. Maybe new cultures need to be sent. Maybe something was missed. But before doing any of that, I ask a simple question. Is the patient actually getting worse or are they simply still febrile? One of the most common overnight mistakes is assuming that a persistent fever automatically means treatment failure. It does not. The inflammatory response does not disappear the moment antibiotics are started. In many infections, fever resolution lags behind clinical improvement. That's why one of the first things I ask is how long has the patient been receiving antibiotics? A fever 12 hours after starting treatment is very different from a fever 5 days later. The clock matters. And the expected fever pattern depends on the infection. Patient with pneumococcal pneumonia, for example, often continues to have fevers for 48 to 72 hours despite receiving appropriate antibiotics. The same is true for pyelonephritis. Cellulitis can be even more confusing. Sometimes the redness appears worse during the first or 2 days of treatment because the inflammatory response continues even after bacterial killing has begun. None of these findings automatically means the antibiotics are failing. This is why I don't focus on the temperature alone. Instead, I ask, is the blood pressure stable? Are oxygen requirements improving? Is the patient feeling better? That's a very important clue. What do the overall trends look like? Is there evidence that the infection is actually progressing? Because persistent fever and treatment failure are not the same thing. Now, there is an important exception here. Persistent fever deserves more attention and evaluation when the diagnosis remains uncertain. A patient with a confirmed pneumonia who is otherwise improving is very different from a patient with persistent fever, no clear source, and no explanation for why they are still febrile. This patient needs assessment. At 2 a.m., don't just ask, does the patient still have a fever? Ask, is the patient getting better? Because fever is only one part of the story. Let's move to the final mistake number 5, thinking the job ends after the page. A nurse pages, doctor, the patient has a temperature of 102. You review the chart, the patient is stable and comfortable, and you decide that no immediate intervention is needed. Then you move on to the next page. This is where many clinicians stop. But the job is not finished. Every fever page should end with a plan, not just for the next 30 minutes, but for the rest of the night and into the morning. After addressing the immediate concern, I ask myself 4 questions. Do I need to reassess this patient overnight? What changes would make me more concerned? When should nursing call me back, right? Very important to tell them that. Does the patient team need to follow up on anything in the morning? These decisions are often more important than the initial order itself. A patient with a low-grade fever and no concerning features may simply need continued monitoring. A patient with persistent fevers may need reassessment later in the night. A patient with a new fever and unclear source may need further evaluation by the day team. So one of the most useful things you can do is give nursing clear callback parameters. For example, please call me back if the temperature continued to rise, for example. Call me back if the patient develops rigors. Call me back if there is any changes in blood pressure. Call me back if oxygen requirements increases. Call me back if there is any changes in mental status. This creates a safety net for the patient and helps the overnight team focus on meaningful clinical changes rather than isolated numbers, and will make nurses much more comfortable. At 2 a.m., my goal is really to solve the entire mystery before morning. My goal is to identify dangerous causes, treat what needs to be treated, and make sure the patient is moving in the right direction. Because fever is not a diagnosis, remember, it's a clue. Remember this. Not every fever needs treatment. Not every fever is an infection. Not every persistent fever means treatment failure. And not every fever requires an overnight workup. At 2 a.m., your job is not to chase temperature. Your job is to identify the patients who need intervention, recognize the dangerous causes, and avoid unnecessary ones. Because fever, again, is not a diagnosis, it's a clue. In the end, if you found this is helpful, make sure to subscribe to the channel and turn on notifications so you don't miss future episodes of 2 a.m. Medicine. And if you would like the deeper dive, practical framework, and additional teaching pearls that did not make it into the video, check out my Substack page and newsletter. Thanks for watching, and I'll see you soon. Link to Substack is in the description field.